This slide is your diagnostic test. They're on page 886 to 890. You guys do need to review over those, especially the stress test. There are different ones. There is a plain stress test, and then there are different ones named cardiolite, dibutramine, persantine, and thallium. Those are just different medications that they are using to speed up the heart rate in order to do the stress test. You need to look at the nursing interventions and any kind of education or teaching you would need to do for your patient. You guys do not need to do EKGs or review those. They will not be on your test. You will learn them in the second year of nursing. So no EKGs, which is on page 891 to 893. And while we're on what you do not need to know, here are some other things that you do not need to know, so you can make a note or mark them out in your book. You do not need to know the table 29-1 on page 880. You do not need to know the table on 29-2, page 884. You do not need to know the box on 29-4, blood pressure assessment. These couple of boxes that I'm telling you you don't need to know, one of them is a lab box because you're going to go by the lab results that are based on your NCLEX Need to Know sheet. And you guys have already done blood pressures. You know how to take a blood pressure. You know that there's a lub-dub, an S1 and an S2 sound that you're hearing because you're doing a systolic and a diastolic blood pressure. The other thing you do not need to know, this is on the assessment techniques. You will not assess the spleen. Actually, you could do more damage if you were poking around on someone's spleen. So we don't teach that method. It's more of an advanced nurse practitioner assessment that they would do, and that's on page 905. So on the next couple of slides, I think it's this slide, and then the next two slides, they're reviewing diagnostic tests that are related to the cardiac system. So I do want you guys to review those in your textbook. We are going to do in the lab activity that will introduce those further. So you do need to review them so that you're prepared that if you come, you may have to answer questions about the diagnostic test. So please review them in your textbook. The one thing I wanted to add in is cardiac lab values. Some of the lab values that are important in regards to the cardiac system are the troponin, the CK or creatine kinase, creatine kinase is a generic lab value that measures muscle damage. So you may see a CK order in various systems. The one that is specific to the cardiac system is called an MB isoenzyme. This actually measures the cardiac heart function as a muscle. The other lab is something called a BNP. The BNP stands for brain natriuretic peptide. So what I do want to tell you is that the troponin, when you're looking for a troponin value, anything less than 0.10, and this is the measurement. And when we're looking at creatine kinase, we are looking at a 25 to 90 for males and a 10 to 70 for females, unit per liter. And when we look at the isoenzyme, it is actually a 0.5 unit per liter. And then when we look at a BNP, we're looking for a result that is less than 100. oops, that's PG per milliliter. So let me talk about these few labs just for a second. The troponin is actually a protein that is found in the blood. It's related to the contraction of the heart, so you can understand why that plays an important key into assessing a patient who maybe comes in and complains of chest pain. The creatine kinase is looking at muscle damage. When we add the MB isoenzyme, we are specifically looking at the heart muscle. And when we talk about the BNP, we are looking at a hormone that is produced by the heart, and it's showing us how well it is functioning. A lot of times patients who are they believe to be in congestive heart failure, they will do a BNP to measure that. So that's just a few of the lab values for the cardiac that I'm not quite sure that are in your book that we will be reviewing in lab. So when we are inspecting and palpating in regards to the cardiac system, we are inspecting and palpating over the pericardium, which we described earlier in the PowerPoint slides. You are looking for essentially a heave or a lift. So as you put your hand on the pericardium, you're going to notice a rise or a lifting type motion. That's abnormal, so you really shouldn't see that. So I'm not talking about putting your hand over the pericardium and you feel the rhythm of the breathing. You are actually looking at the chest wall at the apex and the base itself. When you listen over the pericardium or you listen over an artery, so think of the carotid arteries, you would listen with the bell of the stethoscope. You're listening for a thrill. That thrill is essentially a vibration, a humming sound, or it sounds like a purring cat. That is an abnormal finding that you are hearing. That's called a bruit. So what you would actually do is you would have the patient hold their breath for a moment so that you're not hearing the breath sounds overtaking that vascular sound. You're going to listen with the bell of your stethoscope over top of the carotid artery. You're going to also palpate the carotid artery using your index and middle finger. On the right carotid artery, it's usually the lower third of the neck. You're going to press posteriorly to feel for any pulsations. You're never going to palpate both carotid arteries at the same time. Your patient will pass out. You're going to notice if you feel any disturbances or anything other than a abnormal pulsation when you're palpating. When you're auscultating, you're going to be listening for the bruit. You can also use something when you're looking at the pericardium and you're actually trying to observe if you see any elevations of the chest wall, is use something called tangential lighting. This is lighting that just produces a shadow over the area where you're being observed so you can focus in on it a little better. We're going to start talking about the actual health history and health assessment. When you are taking a health history, what are some concerning symptoms when we're thinking cardiac that the patient may say to you? Some of those could be chest pain, pain that radiates. Remember, we talked about way back in the very beginning, we talked about the old CART terminology, that it's important to know if pain radiates, where does it radiate, what induced it, what maybe were they active, were they squatting, were they moving around, were they sitting still, nausea, diaphoresis. Any time a patient says that they feel like their heart is racing or they have palpitations, this is always of concern. Shortness of breath, difficulty breathing, cough, anytime that they are cyanosis. So you want to think about some of the questions that you want to ask your patient in regards to a health history. And when we ask them questions about chest pain and radiation and shortness of breath, it's the same thing. Can you Tell me, when does it occur? What were you doing when you became short of breath? How many pillows do you have to sleep on at night? If you're asking them about edema, when does it occur? Is it worse in the morning versus the night? Are your eyelids puffy or swollen in the morning? Do you get swollen anywhere else other than maybe your ankles? So you have to think about some of the questions that you would need to ask in regards to symptoms. When we start to think about past medical history, so when we talk about past medical history, we'll want to know, is there any history of heart problems or heart disease? Did they have a history of heart murmurs? Congenital heart disease, rheumatic fever falls into this category. Hypertension, elevated cholesterol, triglycerides, peripheral artery disease, any diabetes, because diabetes kind of falls in every category that we're going to go through. So those are some of the types of past medical history issues that you would maybe ask the patient if they had a history of. We're talking about cardiac, so we do want to ask about a family history. Remember, when we talk about family history, it's usually the parents, grandparents, and brothers and sisters. We want to know the same types of things. Did they have maybe a mother or a father who had a heart attack at age 45? That's important to know. So those types of questions in regards to family history. And then we want to talk about lifestyle habits. Remember, this is going to be that Healthy People 2020 that we talked about. We want everybody to be healthy. We want to promote health, because if we promote health and keep you healthy, it decreases the cost of health care. It keeps you out of the hospital, keeps you healthy longer. So you want to ask them about nutrition, smoking, alcohol. You want to ask them about exercise. When you ask them in regards to exercise, ask them in that open-ended style question. How many times a week do you exercise? What type of exercise do you do? How long do you do your exercise? You also want to ask about medications and drugs. We want to know what kind of medications that they're taking. So this is a picture from another textbook, and it's showing you the different landmarks in regards to what you are going to be assessing when you listen to the heart. So this is a mnemonic that is called Ape to Man. So essentially I'm listening at the aorta. So there's my A. And then I'm going to listen to the pulmonic artery. And then I'm going to listen at the second pulmonic area, which sometimes they will also call Erb's point. Then if you look down, I'm going to listen to the tricuspid. And then I'm going to listen at the apex, which is the mitral valve area. So that is essentially your ape to man. So A for aorta, P for pulmonic, you can do Erb's point, then you're going T for tricuspid, and then the M for the man to the mitral valve area. The other thing you want to note when you are listening to the heart, am I listening to the lub-dub, the S1, the S2? But if I am listening to a heart and I don't hear bum bum, bum bum, lub-dub, lub-dub, and I hear an extra sound, that could possibly be a murmur. Murmurs are just turbulent airflow. So when you listen and you hear an extra sound, you may need to have the patient lean forward or lay on the left side. This actually brings the heart closer so that you can hear better. There are other positions that you could put the patient in depending on what type of murmur they may have. They are heard better in maybe a squatting position, standing position, or a Valsalva type maneuver position. But when you do hear an extra sound or something that is abnormal versus the lub-dub, you need to note where it is, the timing. Is it systole or in diastole? Where do you hear the murmur the loudest on the pericardium? At the base, the sternal border, at the apex? Then we also may have to have them move, like I said, into a different position. You may have to determine the shape of the murmur, and an example of that is a crescendo. Don't get hung up on that part as far as the shape goes. That's going to come if you go into a cardiac specialty, and you will learn that. So don't get hung up on that part so much. Know that you hear an abnormal sound, the timing of it, systole versus diastole, the beginning of it, systole, or the end of systole versus the beginning of diastole or the end of diastole. Know where it's located the loudest on the pericardium. Note that there is a grading system that will grade murmurs. So a 1 to a 6 is the grading tool used, 1 being very faint, hard to hear murmur, 6 being extremely loud murmur. And you also want to listen, when you listen to the heart and you're listening to heart sounds, you want to listen in a room that is quiet. You don't want the TV blaring. You're not going to get an accurate sound on what you're listening to. You also want to note the rate of the heart rate when you're listening. When I talked about extra heart sounds or murmurs, they can be an S3 or S4. The S3 is actually caused by the rapid rush of blood into the ventricle. It's called a ventricular gallop. Murmurs are always heard better with the bell of the stethoscope. An S4 is caused by the atrial contraction of the blood into a non-compliant ventricle. It is also best heard at the apex with the bell. This is just a few of the techniques that could be used in order to hear a murmur better. Just be cautious anytime you have a person do a valsalva or move, they can pass out on you. So when we're talking about a cardiac assessment, you always want to do a heart rate and blood pressure. You may have to do an assessment for orthostatic hypotension. You guys know how to do blood pressures. You guys know how to do a lying, standing, sitting blood pressure. We're going to skip the part that says assess the lymph nodes, because that part is actually going to be in your lymphatic chapter, which will be next week. You always want to assess capillary refill. It should be less than 2 seconds. Essentially what you're doing is you're checking the nail bed. You put your finger and you press down and you look at the refill time and count in seconds how long it takes that color to go from pale to color. You always want to auscultate the carotids and assess. You use the bell of the stethoscope. Remember, you do not occlude both carotid arteries at the same time. Your patient will pass out. You are always checking pulses. There are 9 different pulse sites that you can check a pulse. You can check the temporal pulse, carotid, the apical pulse, brachial pulse, radial, femoral, post-tib, dorsalis pedis is the pulses that you would check. They are rated as a 0 to a 4+, 0 being no pulse, 4+ being nice and bounding. The other thing that you can do is assess jugular vein pressure. You want to elevate the patient's head of the bed. You do want to turn the patient's head to the side. And what you are essentially looking for is the distension that is visible of the jugular vein. You're going to look between the mandible and the outer clavicle. This is on page 902 for you to review, and I think I have another slide that has a picture that's showing you how they essentially take the measurement to get that 3 centimeters or less. So when you're looking at this side, this just continues the health assessment for the cardiac system. You guys do need to refer to or review the Allen's test. This is the test that they use on how to obtain ABGs. They're also looking for artery insufficiency. You're going to assess the abdomen. You want to note the patient's size, the width, and any visible pulsations or bulging. You do not want to hear bruits in the abdomen. You do need to review the different sites in which you would auscultate on the abdomen on page 905. You want to review the aorta, renal, iliac, and femoral. The thing you do not need to know, and you guys can make a note of it in your book, is assessing the spleen. The spleen is not normally palpable, and it is something that typically the advanced nurse practitioner will do, or the physician. We've already talked about edema and rating it. One place it tells you to start at 1+, the other starts at 0. 0 is always going to be there's nothing. You have no, oh, I'm sorry, I just got confused. We're talking about edema. Edema is rated 1+ to a 4+ in regards to pitting. You have to assess edema. This is a picture from another textbook showing you how to measure the jugular venous pressure. What you are looking at is the true vertical and horizontal lines that measure the jugular vein pressure is difficult to establish. So what you need to do is place your ruler at the sternal angle and line it up with something in the room that you know to be vertical. Then you're going to place a card or some kind of a rectangular object. In this particular picture, it looks like they use the little Q-tips that come in a pack. And you're going to put them in an exact right angle to the ruler. So as you can see, change my pen colors, you have a right angle. And when we're talking about a right angle, we're talking about that sternal angle is what we're looking at. So you do have to round the measurement off to the nearest centimeters, and that gives you a measurement of venous pressure measured. So this is another assessment tool that you can use in the cardiac system. This slide takes you to a couple of YouTube videos listening to the S3 and the S4 heart murmur sound and a full cardiac assessment, so you can kind of put all the pieces together. The other thing I want to talk about before we go is just some health promotion type things. The nurse always plays a role in regards to health promotion. We can screen our patients for disease and risk factors. We teach our patients the relationship of the risk factors to the disease. We always educate our patients on lifestyle changes. Remember the diet, exercise, smoking, and we want to reduce those risk factors. We also want to encourage our patients to adhere to healthy lifestyles and to continue their medical regimen, whether it be getting their blood work drawn, following up with their primary care physician, because we want to reduce disease and we want patients to be healthy and live longer. So this pretty much concludes the cardiac part. I do want you guys to keep in mind when we think of modifiable risk factors versus non-modifiable risk factors. Start to think about what are some of those. What are some modifiable risk factors? Diabetes is a modifiable risk factor. However, an increase in your age is not a modifiable risk factor. That's going to happen to us no matter what. So just start to think about this. If you guys have any questions, feel free to email me. Remember, the cardiac chapter 29 is divided up into 2 weeks. So part of it is going to be all cardiac. And then the following week, we're going to talk about the lymphatic system and the importance of the lymphatic system. Okay, thank you. Have a good day.